We've somewhat run out of time, so I think we'll keep the questions perhaps to a relative minimum, perhaps one question for each of the speakers. Anyone in the audience? How do we choose? Elijah.
Clearly not on Luke's.
Probably loud enough without the microphone, actually. This is for Professor Sharma. You mentioned about false positives and false negatives, and I just wondered, when you mentioned about 4 to 15% of African-American athletes would overlap with the established criteria, what's your gold standard? Did you detrain them?
Well, I think what we have to do is firstly appreciate what's normal in those individuals. What I was trying to say was that if we took into account the major criteria, ECG criteria for ARVC, then we've got two-wave inversion in V1 to V3. That would be about 14% of those. And if we took into account major criteria for echo, that would be about 28%. Then, obviously, if you combine all those, then 3% of Afro-Caribbeans would fulfill possible two major criteria. What I didn't say, because of lack of time, was that we look for function. If you start looking specifically for regional wall motion abnormalities, then you do reduce that false positive down. But I would say that if you're going to look for regional wall motion abnormalities, I would rely on MRI over echo.
Question at the back on the left.
Question to Costas. Congratulations for having the findings of your study implemented in the European guidelines so quickly. I do wonder, have you asked yourself whether perhaps they've been implemented into the guidelines too quickly? And because rarely have I seen such translation into widespread clinical recommendation. And I note that you're undergoing further validation studies and so on. So my question is, maybe you should have waited for those before pushing for the European guidance.
Sure. That is a very valid point. I think there is enough data to show that what we were doing before was not working. I think that's undisputed. I think there's also enough data to show that this method is, at least as good or better than what we're doing. And certainly the previous method was just, it really wasn't based on data, it's based on relative risk, which has no place in treatment. So I will not claim that this is perfect, and I'm sure this will not be the last iteration. It was peer-reviewed for both publications and accepted. And a similar thing happened with CHADS-VASc when it was implemented by the AF guidelines. So I agree with you, there is a risk that next year we may find that actually it's not as good as there is. But at least we're in an active process of moving forward and using more data to improve patient outcomes.
Costas, one of the things that's missing from that risk model is late enhancement on MRI imaging. How important do you think late enhancement is?
At the moment, there's not much data to suggest that we can use it. Essentially, the largest study was published 3 months ago. It was published in Circulation. It includes 1,300 patients, and it shows some association, but the multivariable analysis is flawed. Essentially, we don't have enough patients with late GAD to answer that question.
Sorry, that was my question.
Anyone else?
Can I ask a question of Dr. Bezzina, of Connie Bezzina? You have published as well on genome-wide association studies in cardiac arrest in the setting of acute ischemia, and in the setting of, and you've participated in replication in GWAS of sudden cardiac death as a general phenotype. Is your impression of those initial forays into looking at sudden cardiac death as a phenotype in the general population as opposed to the monogenic disorders, that we've got a future in risk prediction with genetics, or do you think we're really fighting a losing battle with that particular phenotype?
Yes. So basically, as you've mentioned, we've published one study, and we we try to focus on a very, very specific phenotype, which is ventricular fibrillation in the setting of a first MI. We expanded that study. We found the same one locus. There have been reports of people who have not replicated that locus. I think there's a appointment in the field that we're not finding robust loci, essentially. And we don't know why. I personally think it's a question of the large variability in the pathologies that underlie VF in the community. I mean, you can have VF in the setting of a clean heart in the first MI. You can have VF in the setting of some degree of myocardial scarring. You can have VF in the setting of heart failure. And I think that we need much larger population sets to study that are much more deeply phenotyped than we're studying now. And I also think even in the very specific phenotype that we think we chose in the EGNIS study, which is VF in the setting of a first MI, you could also have a stratification based on the culprit artery. So I think even within that phenotype, we have to go deeper and classify patients even more accurately in the hope that we will find genetic factors. But it is, at the moment, indeed very, very frustrating phenotype to work with.
Oh dear.
Can I ask a question about the populations you do genotype? Some of your examples there showed the importance of founder effects, particularly in the Dutch populations and also Dutch populations that have moved abroad. Struck during Sanjay's talk about the discussion about ECGs in Africans, and African population really is actually very genetically diverse. Does it matter in whom you do your population studies?
Absolutely. First of all, for genetics, it matters very much that you work in a defined population. Doesn't matter which one it is. You have to match your cases and controls, especially if you're working with rare variants, because these have a more recent origin, and you could have certification based on that. Most studies are done in Caucasians, although some genome-wide association studies are starting to be done in African Americans. But I agree that more studies need to be done in more diverse groups, and we also need to see whether associations apply across different ethnicities. Now, going back to the comparison with the phenotype mentioned by Elijah, I mean, we think that the inherited disorders, even though genetically complex, are more amenable to gene discovery simply because these patients have one big hit already, which makes the situation permissive to the discovery of more genetic factors.
One more question.
My question's for Professor Sharma, but maybe for everyone. But in my clinical practice, I have a lot of problems around the ethics of screening. Obviously, we don't have prescribed screening in the UK, but what way do you approach the consent to the screening for participation in sport? And then subsequent to that, how do you deal with the advice that is not taken up by an individual and their family and their involvement then in organised competitive sport?
Again, that's an excellent question. Let's deal with this quickly, because I know you're all hungry. But in terms of, I look after two types of individuals. I look after elite sportsmen, and I look after recreational athletes and maybe even school children. In terms of elite sportsmen, I think the ethics are there. It's a club's mandate that a young individual is tested. The club usually calls the shots. If you don't have the test done, they won't play you. That's how it is. And so when Chelsea send me a player, I'm answerable to the Chelsea doctor, and the player arrives on the understanding that if a diagnosis is made, it could prove costly. The second point that you make is much more sensitive and much more pertinent, and that is testing a 17 or 18-year-old who has come along, who wishes to be tested, just because they're a little bit worried, and then something is identified. Our screening program at CRI, the consent form is very, very carefully structured, which provides all the cons of having a diagnosis, including the need for additional tests, the psychological concerns that may arise, the possibility of an erroneous diagnosis, disqualifications, big loans because insurances don't take you on. That's all available before someone actually signs on the dotted line. The third thing that you talked about was when you make a diagnosis and someone doesn't listen to what you're saying. And it's like everything else. I think if you have someone who's had a myocardial infarction that's going to carry on smoking 20 cigarettes a day, all you can say is as the individual ambassador, is don't do it. So I advise, but I don't necessarily believe, and never have done, in disqualifying a young individual from playing sport, because the event rates at the end of the day are quite small.
That was a very nice way to close. Thank you, Sanjay, and it's lunchtime.